here in Toronto. It is for me great joy to introduce Dan Keefe, who's one of our senior fellows, who's going to talk about a topic that I think is incredibly important for anyone who takes care of children and adolescents with oncological problems. So I am very excited that Dan is going to give the talk. However, in preparation for that, we're going to just have a small parenthesis, and Karen is going to tell us a little bit about how we're going to deal with questions and the chat. Karen, go ahead, please.
Hi, everyone, and thank you for joining us again this morning. As you know, this talk will probably be about an hour to an hour and 15 minutes long. If you have any questions, there's a Q&A box at the bottom. You can type your questions and we'll answer them towards the end, or type any quick answers as we go. At the end, if anybody would like to ask questions out loud, we can give you the mic as well. Just a reminder that we have these webinars sort of once a month on the last Friday of each month. And there is a mailing list. You can contact me or Michael Chua if you'd like to be added to the mailing list, or you can follow Dr. Lorenzo's Twitter feed for updates. Thank you very much, Dan.
So thanks, Karen and Dr. Lorenzo, for the introduction and for kind of going over how we're planning to do this. I'm going to make the assumption that you can all hear me. And I want to thank everyone that for coming to hear us talk. And this is a topic that's known as diagnosis and management of pediatric testis tumors. So welcome to everyone from here in Toronto, as well as others joining from elsewhere in the world. This talk is supervised by Dr. Lorenzo, who's going to help with some moderation, and we'll do some questions likely at the end. So the outline for this talk is listed here. So we're going to review epidemiology of testicular tumors, and then go into some detail about testis tumor risk factors. We will then discuss how to make the diagnosis as well as management of the most common testicular tumors in both a prepubertal as well as postpubertal setting. So this is going to include a review of the main surgical options depending on the presumed etiology, including testis-sparing surgery, radical orchiectomy, and retroperitoneal lymph node dissection. So lastly, I want to talk a little bit about what I've collectively termed testis cancer survivorship. And this will be focusing on fertility concerns, secondary malignancies, as well as some body image issues and considerations for prosthesis. So I have no disclosures. All of the photos, aside from those directly cited, are courtesy of Dr. Lorenzo. I do, however, have a few caveats. First of all, this talk is meant for a very broad audience with varying backgrounds and experience in treating testis tumors. Secondly, it is not meant to be a comprehensive review of all scrotal pathology. So some of the benign conditions and paratesticular pathologies are not represented. Lastly, I will definitely be focusing much more on prepubertal testicular tumors and just touching briefly on postpubertal tumors, which definitely have a different management algorithm. So we're going to start with a very brief case scenario. So you're a pediatric urologist or pediatric urology practitioner who's triaging referrals when you receive a letter from a pediatrician who's referring a 2-year-old male found to have an incidental testicular nodule on exam. Being concerned and an astute clinician, you triage them urgently and are able to get them to clinic within a day or two after receiving the referral, and they're coming today for assessment. So as you wait for the patient to arrive, you start to think a bit ahead of what the most important considerations are for a patient in order to provide them the best care. So the first thing you think about in this limited history is the patient age of 2 years old. Patients with testicular cancer are known to exhibit a bimodal distribution of presentation. And you can see that this is outlined in this graph, which was published in the Journal of Cancers earlier this year. So early in life, within the first 2 to 3 years, there's a higher rate of both malignant germ cell tumors as well as teratomas. And during and after puberty, we see a second spike and a sharp increase in malignant germ cell tumors primarily. So of note and very important consideration is that teratomas, as outlined in the green graph here, are benign in the prepubertal setting and become malignant in the postpubertal period. So the patient's age in this clinical scenario fits a higher risk period, somewhere in this spike, for testicular cancers. So you also start to think about how these patients generally present to medical attention. So we know that most testicular tumors are discovered in either a self-examination in older patients or clinical exam, often routine clinical exams. So there are also a significant amount of patients that are identified to have subclinical masses that are identified incidentally on ultrasound for other reasons, for example, for pain. A really important thing to keep in mind is that malignant tumors can also present with reactive hydroceles. Hydroceles, obviously, in our clinics are very common, but it's important to be mindful of the clinical history and to palpate the testicle for masses. If you have any concerns whatsoever on physical exam, it's reasonable to consider an ultrasound. However, obtaining an ultrasound in every patient with a hydrocele to rule out cancer would probably be a misuse of some of our limited healthcare resources, so I would use that sparingly. But it does present in about 15 to 20% of malignant germ cell tumors with hydrocele. I also wanted to touch base on another, I guess, manner of presentation that we were taught to be mindful of. So if a patient presents with a very low impact and kind of benign sounding blunt testicular trauma and suddenly develops a testicular rupture, it's possible that this actually represents a rupture of a testis mass. So this CUAJ case report and review of the literature outlines that this is pretty rare, with actually only 6 cases reported in the literature until that point. But I think this may be an underrepresentation because not all of them are presented. I can think of 2 cases in residency where this happened. So it's really important to review the ultrasound images closely. If you suspect a testicular mass associated with a testicular rupture, it would change your approach to a surgical exploration from a scrotal approach to an inguinal approach, and you may even consider orchiectomy. So this is obviously an important consideration. Upon triaging this patient, you started planning his workup, including a history, physical exam, and key investigations, including a scrotal ultrasound and blood work. So you've placed all of these orders for these investigations so that when the patient arrives, they can get their blood work done and their ultrasound done and be available for your review when they come to clinic. Metastatic workup will really depend on the underlying testicular pathology and is often not necessary in some of these cases. And we'll discuss that a little bit more down the road here. It's also very important to start considering a differential diagnosis for a testicular mass in this prepubertal age group. And this can help guide your triaging as well as your workup and kind of expedite care as needed. So the differential diagnosis of a prepubertal testicular mass has changed a significant amount over the years. Earlier studies based on the AAP registry, which is outlined here, there was a prepubertal testis tumor registry. And this outlined that yolk sac was actually far and away the most common presentation of a prepubertal testis mass. But when you actually looked at this data a little bit closer, there were significant biases given that many of the benign pathologies identified did not get placed in the database. And so the numbers were skewed by a selection bias. Usually only the malignant ones, or often the malignant ones, would get added. So more contemporary studies showed that benign pathology actually predominates in prepubertal testis tumors. And this happens approximately 2/3 of the time in this age group. So much of this data where there's been a kind of a change in the differential diagnosis was actually learned from studies of patients at Sick Kids. And I've posted both of these studies here. So you may recognize a few familiar names up there, including Dr. Bagley, who took part in these research studies. So in the top study, it's of 51 Sick Kids specific patients from 1984 to 2002. And as you can see here, the primary pathology in these testis mass patients was teratoma in 43%, with yolk sac making up only 8% of these patients. So far different than those AAP numbers. Then they compiled data from 4 centers as well, including Sick Kids. And in this larger study, again, teratoma predominated with 48% of the pathology, and yolk sac represented about 15%. Some of the other prominent masses included epidermoid cysts and gonadal stromal tumors like Leydig and Sertoli cell tumors. So in this 2-year-old patient coming with a testicular mass, we know that a benign pathology is more common and that there is generally a more favorable course which can help provide some reassurance. However, it's very obviously important to be cognizant that a malignant tumor could be the cause. Overall, these tumors are quite rare. Testis tumors make up only about 1% of pediatric solid tumors, with an incidence of 0.5 to 2 per 100,000 children. So very uncommon tumors overall. So the patient arrives to your clinic and you complete a usual history and physical examination. The patient had a regularly scheduled clinic visit with the pediatrician, who very astutely noted a mass on the right testicle on routine physical examination. He's now 2 years old and was born at term, otherwise completely healthy and meeting all of his milestones. Family history was non-contributory in this case. On physical exam, you can palpate the right testicular nodule. He does not react on exam, indicating that it is not likely tender. There's no hydrocele, and both testicles are descended and equal in size and consistency. So during your history and physical, you're starting to also consider that a thorough clinical review is important to know what the risk factors are for testicular cancer, and I want to talk a little bit about those. So there are a few main established risk factors for malignant testicular germ cells. These are namely cryptorchidism, both a family as well as a personal history of testis malignancy, and pathology showing evidence of germ cell neoplasia in situ, or GCNIS, which was previously known as intratubular germ cell neoplasia, or ITGCN. Some other less well-established risk factors include infertility, HIV, gonadal dysgenesis, testicular feminization, and Klinefelter syndrome. Importantly, risk factors for malignancy do not include prenatal estrogen exposure, as we previously thought. So these risk factors are actually most commonly associated with post-pubertal malignant germ cell tumors, but I think it's really important to keep these in mind and when you're seeing a patient with a testis mass, and we'll touch on a little bit of these individually in the next slides. So I think this is probably one of the most important ones for us as pediatric practitioners, pediatric urology practitioners. It's a really important risk factor for testicular cancer, and is something that we see very commonly in our clinics. So cryptorchidism, we should know how to discuss with families and counsel regarding this. So I posted this study here, and this is a Swedish study which was published in the New England Journal of Medicine in 2007. It identified 17,000 patients that underwent orchiopexy, of which about 56 patients developed testis cancer. So they looked at the age that the orchiopexy was completed and assessed what the risk for testicular malignancy was. So you can see that both groups had an increased relative risk of testicular cancer. However, those who underwent surgery after the age of 13 or post-pubertal had a higher risk, relative risk of testicular cancer at 5.4, compared to those who had an orchiopexy that was done before puberty with a relative risk of 2.23. So they also noted in this study that the higher the testicle at surgery, the higher the risk of testicular cancer. So when I counsel patients and parents after orchiopexy, I always explain this risk in detail because it can be concerning. They may search this online and find this information. And the main thing that I want to do when I see these patients is provide context. So when you consider that testis tumors are so rare with a baseline of 0.5 to 1 per 100,000, and that's an absolute risk in the general population. When you consider cryptorchidism increases that by, at the most, let's say 5 here, that would be about 5 per 100,000 patients. So it's still quite uncommon overall. So patients with cryptorchidism should be counseled on testicular self-exams and encouraged to seek medical attention if a testis mass is noted, and no additional surveillance or screening is necessary and probably wouldn't be cost effective in our health system. Family history of testicular cancer is also very important. So this study, which is also a Swedish study, and it was published in Nature in 2018, exposes this risk. So this is from a family cancer database in Sweden, and this was assessed from 1958 to 2015. And a total of 191 familial testicular cancers were identified, which represented 2% of all the testicular cancers. So if a patient had one first-degree relative with testicular cancer, their relative risk of developing cancer was 5.06, and seminoma and non-seminomatous pathology were relatively equal, with one first-degree relative. In patients with 2 first-degree relatives, the relative risk skyrocketed up to over 30, and non-seminomatous pathology predominated. The risk was higher if you had a brother with testicular cancer compared to a father. However, both of these were actually independent risk factors, with a brother being 7 and father being around 4. This one is often not discussed and is very important, I think. So patients with a personal history of treated malignant germ cell tumors should be counseled to remain vigilant in their self-exams, as they are at a significant increase in contralateral testis tumors, which would obviously be very devastating to hormone production and fertility. So there's a 12-fold increase of contralateral testis tumors, although overall the 15-year cumulative incidence remains relatively low at 2%. So if caught early, these tumors may be amenable to testis-sparing surgery for functional preservation. Germ cell neoplasia in situ I mentioned very briefly earlier. This is, I guess, more potentially a risk factor, but also a pathologic finding, which is probably most consistent with almost a precursor state. So as you can see in this diagram, which was published in the International Journal of Urology, you can see that this is germ cell neoplasia in situ here. And this then gives rise to germ cell tumors. And it happens directly from primordial germ cells, so even early in life or even before, actually. So in patients with invasive germ cell tumors, GCNIS is found in adjacent testicular parenchyma in 80 to 90%. So at radical orchiectomy, if you look at the surrounding tissues, you often find this pathologic finding. And it's an important thing to consider when you're considering testis-sparing surgery, especially in post-pubertal patients, as this predicts the risk of a germ cell tumor in the remaining tissue. Somewhere around 50% of those with GCNIS will develop testis cancer in 5 years, and 70% in 7 years. The other thing that's been established is that 5 to 9% of germ cell tumors will have GCNIS in the contralateral testicle, which is important for counseling patients about being vigilant in examining the contralateral testicle and may be part of the risk of developing contralateral tumors. Testicular microlithiasis, this is definitely a controversial topic, and it was traditionally felt to be a risk factor for malignancy. This was based on a Journal of Urology study back in 2008 that followed up on very healthy Army volunteers. So 5% of these healthy volunteers were identified to have microlithiasis, and on longer term follow-up, 1 out of the 64 men went on to develop a germ cell tumor. In pediatric literature, the incidence has been quoted to be about 2.5%. So this study prompted many to recommend screening ultrasounds, and some places recommended up until the age of 55. And since that time, most recent studies have primarily recommended surveillance in patients with microlithiasis, only if associated with features such as atrophy or a prior history or family history of testicular malignancy. So we generally do not recommend surveillance ultrasounds in patients with isolated microlithiasis, and we counsel for testicular self-exams similar to the general population. So getting back to the case, you're now able to review the ultrasound obtained on the same day as your clinic visit. Ultrasound is an excellent tool for helping diagnose testicular masses with a sensitivity that approaches 100%. The big thing to note here is that it really cannot distinguish between benign and malignant processes. Some of the more classic features on ultrasound of a testicular mass are that they are often hypoechoic, as seen on the image on the round mass seen in the second ultrasound picture. Depending on the pathology, they could be either heterogeneous, as often seen in non-seminomatous pathology, or homogeneous, as we see in seminomas. Using the Doppler, you can often demonstrate vascular flow within the tumor. One word of caution is that at times, if you have a retroperitoneal mass or a concern for an advanced germ cell tumor, and then you do a testicular ultrasound, you may not identify a discrete mass as this could be a burnt out tumor, or you may even just see a scar, a little remnant of a tumor that's subsequently spread. So in these cases, it's really important to know the pattern of spread of the tumor through the lymphatic system primarily, and still complete the orchiectomy despite the normal ultrasound. So we'll touch on the pattern of spread when we talk about retroperitoneal lymph node dissection later on in the talk. So patients with testicular masses should also be evaluated with serum tumor markers. In post-pubertal patients, it's really important to obtain each of the AFP, or the alpha-fetoprotein, beta-HCG, and LDH. These markers can give us an idea of the underlying pathology and provide information on staging that really guides management. So I put some of the statistics here about how frequently these are elevated depending on the pathology and stage of disease in post-pubertal patients. In pre-pubertal patients, the most important marker and the one that needs to be obtained is the AFP, which can determine if the mass represents a yolk sac tumor. So as mentioned, AFP is very important for evaluating pre-pubertal testicular tumors. It's important to know a bit about the natural history of AFP. It's produced under normal circumstances by the fetal yolk sac, as well as the GI tract and liver. It can often be elevated in other conditions, including malignancies and benign conditions of the liver and GI tract. And the really important thing for us to know is that it can be elevated under normal circumstances in newborns and younger infants, even up until the first year of life. So generally, AFP is elevated very early on in life due to the fetal yolk sac production, and it has a half-life of about 5 days. So as the baby gets older, the AFP clears, and you can see this trend that I showed here. Over 6 months, it should start to normalize, but sometimes this persists even up to a year, which could have implications on management of testis masses. So this diagram I took from Campbell's textbook. It outlines a diagnostic algorithm that you can reference when making management plans for prepubertal testis tumors. So as you can see at the top of the algorithm is the serum AFP. If it's elevated and the patient is 1 year or older, the patient should proceed with radical orchiectomy. So if it's normal and the rest of the testicle appears healthy, it's reasonable to consider testis-sparing surgery, as we know that there is a high likelihood of benign pathology, as I mentioned earlier, in about 2/3 of patients. So you can also consider sending frozen sections intraoperatively and transition to radical orchiectomy if there are any concerns for a malignant yolk sac tumor. So moving back to the case of the 2-year-old boy with a testicular nodule, the ultrasound shows a right 1 centimeter testicular mass that is hypoechoic and also exhibits some vascularity. Very importantly, he also has elevation in his serum AFP levels, and you therefore are worried about a yolk sac tumor, so recommend urgent surgery with a radical inguinal orchiectomy. So we're gonna take a bit of a pause from some of the didactic stuff and do some photos and look at some of the radical inguinal orchiectomy principles. So these images here show the radical orchiectomy of this patient. So you can see a right testicular mass clinically on examination in the image on the top left. We then do an inguinal surgical approach, and the spermatic cord is identified and secured with a silk tie, which is done early in the procedure. The testicle is then delivered into the field, and on the image on the right, you can see further dissection of the cord proximally aiming towards the internal inguinal ring. You can also see the preserved ilioinguinal nerve here as well. So here are a few more photos of the same orchiectomy. So the testicle is delivered into the surgical field. This is after everting the scrotum and dealing with some of these gubernacular attachments, taking caution not to violate the scrotum or the tunica vaginalis. The testicle is then excised, which you can see here. We were able to dissect this all the way up to the internal ring, and then it was ligated, suture ligated at this level, and this was the specimen sent for pathology. So some of the principles of a radical orchiectomy include early low cord control, but high transection at the level of the internal ring. Especially in bulky tumors that involve the cord, it is preferable to isolate and control the vas separate from the vessels, although generally this is not always required, especially in prepubertal patients with small cords. It's also important to control the cord with a non-absorbable stitch, like a silk that was done in that case that I just showed, and leave the tails of the stitch quite long, and make sure that you push the cord stump into the retroperitoneum. And this will help make identification easier should a retroperitoneal lymph node dissection be required in the future if they have more advanced disease. You also want to avoid violation of the tunica vaginalis and scrotum to not impact the pattern of spread seen in most testis tumors following a lymphatic drainage pattern. And if necessary, you need to deliver a large tumor, the incision should be extended from the inguinal area to the scrotum. So our patient underwent a radical orchiectomy, and pathology confirmed the diagnosis of a yolk sac tumor. There was presence of a pathognomonic finding of this tumor, which is Schiller-Duval body. I took this photo from Campbell's textbook. Staging was done with a CT abdomen and pelvis and chest x-ray, which showed no concern for metastatic disease. And thankfully, his 1-month follow-up showed a decline of the AFP toward normal, which provides further reassurance. And this is generally what we do in yolk sac tumors, as 5 half-lives of 5 days ends up being close to a month. So yolk sac tumors are a malignant tumor and were classically felt to be the most common pathology behind prepubertal testicular masses, although we saw that trend go away on more contemporary studies. These tumors are endodermal sinus tumors and occur most commonly in the first 2 years of life in about 75% of patients. The vast majority, about 60 to 90%, will have elevated AFP levels, but importantly, half of these patients with elevated AFP will not have metastases. 80% overall are stage 1 and therefore are generally cured with radical orchiectomy alone. Metastatic disease should be considered based on the pathology, which may exhibit higher stage, or as well as things like persistently elevated AFP levels at 1 month post-op, which would give you an indication that there may be some yolk sac cells elsewhere in the body producing AFP. So if there's concern for metastases, they should undergo CT abdomen and pelvis as well as chest imaging. Thankfully, chemotherapy is quite effective in these cases, which is important, as many of these actually spread via both a lymphatic and hematogenous method. Recurrence is also found in about 17% of patients, so monitoring serum AFP levels in the postoperative period is quite important, as this is a very sensitive marker for recurrence in yolk sac tumors. So this is the Children's Oncology Group's staging for prepubertal testis tumors. The patient was a stage 1, as is the most common situation. So based on the COG staging protocol, it's recommended that patients proceed with metastatic evaluation, including a CT abdomen and pelvis, as well as a chest x-ray. This, however, is becoming slightly more controversial, and many experts prefer to make decisions based on the individual patient and do so in conjunction with the oncology team in a multidisciplinary setting. Much of the controversy surrounding staging and surveillance has been addressed in this study, which Dr. Lorenzo took part in. This is a study that was done at Sick Kids as well as multiple other pediatric oncology centers throughout North America. It's a study from the Journal of Clinical Oncology, which was published in 2018, and it looked at 284 patients with malignant germ cell tumors. 7 patients had normal tumor markers at diagnosis, and none of these patients actually experienced a relapse after initial therapy. Of those 284 patients, 48 of them ultimately underwent or experienced, I guess, a relapse. And of these 48 patients, 47 of them were picked up by recurrence of serum tumor markers. The only other patient that was not didn't have serum tumor markers at the time of the imaging. So not really sure if it would have been also noticed on tumor markers as well. So these patients were followed for a median of 5.3 years. And the conclusion of this multi-center study was that in patients with malignant germ cell tumors, serum tumor markers are sensitive indicators for relapse, especially in those who presented with elevation at diagnosis. So the goal of this was to reduce the quantity and frequency of surveillance imaging, each of which provides a cumulative increase in radiation exposure and places younger patients at risk for development of later secondary malignancies. Switching gears away from yolk sac tumor, the yolk sac tumor case that we were discussing, I really want to touch on the most common prepubertal testis mass pathology, which is teratoma. So as we discussed, this is a benign tumor in the prepubertal setting and considered malignant in post-pubertal patients. It should be suspected in patients with a testis mass and no elevation in AFP, and it's derived from all three germ cell layers, specifically the endoderm, mesoderm, and ectoderm. In post-pubertal patients, I will mention that this type of malignant tumor is resistant to chemotherapy. As with all of these tumors, the diagnosis is confirmed on pathology of the specimen. However, if your index of suspicion is high that this is a teratoma, it would be really reasonable to consider testis-sparing surgery. So I'm going to show you a case of kind of an interesting one. So this patient was seen at Sick Kids, had a noticeably large left testicular mass. At some point, he received an abdominal X-ray, which was maybe for other reasons. But interestingly, you can see some calcification in the left hemiscrotum, where you would expect the left testicle to be. And then he had an ultrasound showing a large heterogeneous mass in the left testicle with some acoustic shadowing noted here from the intratesticular calcifications that we can see on the ultrasound. So these findings are really supportive of a teratoma, which can exhibit mature tissue types, including calcification. So this patient ultimately went on to have a radical orchiectomy due to the large size of the tumor. You can see in this image that the incision required extension down toward the scrotum from the inguinal area, which is something that I touched on when talking about the principles of a radical orchiectomy. And this is really important so that you're not trying to force the testicle out through a small incision and risk rupture of a potential malignant tumor. So in the previous case, the testicle was not amenable to testis-sparing surgery due to the size, but since teratomas are benign, I wanted to show some more photos of a patient who was able to undergo partial orchiectomy for what was ultimately determined to be a teratoma. So this is an infant male who was identified to have a right testicular mass with negative markers. Ultrasound revealed heterogeneous, well-circumscribed intratesticular mass, and you can see that there are some cystic appearing components within the mass in this area. So intraoperatively, you can see a larger right testicle as compared to the left hemiscrotum. We did an inguinal incision, and early cord control was obtained using a vessel loop. The testicle was delivered into the field. During testis-sparing surgery, it can sometimes be really straightforward at delineating the mass. So here we can see that upon incising the tunica albuginea, we encountered the capsule of the mass, and we were able to continue the dissection of the capsule of this discrete nodule away from the underlying normal testicular parenchyma. So sometimes masses are not so well encapsulated or are really small in size, and using an intraoperative ultrasound can help guide tumor resection. Here you can see again the very discrete nodule being dissected. So this is the nodule completely dissected away from the rest of the testis, and you can see that it's kept intact. And then over here, you see the defect left when the mass was removed in completion. And here it is here, and then we transected it at this level here. Pathology ultimately revealed a benign teratoma in this patient. So one major consideration is that, which is also thankfully uncommon, is whether testis-sparing surgery is safe in those with who present with a peripubertal mass or somewhere around the time of puberty. So in these patients, we do not have evidence that partial orchiectomy is safe. And if there is any doubt, you can consider biopsy of normal surrounding tissue, assessing for evidence of spermatogenesis. So if this is present, likely these patients should be managed with orchiectomy, as the most important goal for all of these patients is oncologic outcome. Epidermoid cysts are a relatively common finding in about 10 to 15% of prepubertal testicular masses. These are benign tumors of epidermal origin. And there's a consideration that these masses may fall along the spectrum of a teratoma, however, are represented by only the epidermal cell type as opposed to 3 different cell types in teratoma. These masses have a characteristic finding on ultrasound. So I borrowed this image from Radiopedia, which demonstrates the characteristic onion skinning pattern seen on ultrasound. So with an ultrasound showing this finding in negative tumor markers, you should be considering testis-sparing surgery as well. So this is an example of a patient who underwent a partial orchiectomy, which was diagnosed on pathology as being an epidermoid cyst. You can see here a well-circumscribed tumor, and then the tumor here with the defect created in the testicle, which was repaired after hemostasis. And then again on transection, you can see some characteristic findings. So there's some keratinized epidermal cells and layering within this tumor consistent with an epidermoid cyst. So we're next going to go into the 4 main sex cord-stromal tumors, which are Leydig cell tumors, Sertoli cell tumors, Granulosa cell tumors, and gonadoblastomas. So Leydig cell tumors are another important cause of pediatric testis masses. These are the most common sex cord-stromal tumors, and based on the studies I presented earlier, represent about 4% of these tumors in this age group. These are benign lesions with no cases of pediatric patients having metastatic or malignant disease. Approximately 10% of patients will present with precocious puberty, as they are hormonally active tumors that secrete testosterone. Some patients may present with a painless mass, which is the usual finding. Some may present with signs of precocious puberty or gynecomastia. Erectile dysfunction and infertility can be seen in older patients. So in this young patient who we'd expect to be prepubertal, physical examination revealed evidence of pubic hair in this area, as well as some scrotal hair following kind of the pattern of the right testicle. So he underwent a complete endocrinologic evaluation and ultimately underwent a scrotal ultrasound. So the ultrasound revealed a small hypoechoic lesion in this image here. And given his clinical presentation, there was concern for a potential hormone-producing tumor like a Leydig cell tumor. Given the small size on the ultrasound, we did need to use the ultrasound to identify the mass intraoperatively. Once the tumor was localized and marked, we began to excise it, and we sent this for pathology and repaired this small defect, thus salvaging the rest of the testicle. Leydig cell tumors may show a pathognomonic finding. These are called Reinke crystals. Again, this photo was taken from Campbell's as well. This is identified in about somewhere around 25 to 40% of Leydig cell tumor specimen, and if you find it, it really helps to make the diagnosis. So this is a study from 2019 from the group here at Sick Kids. It's the largest series of patients with Leydig cell tumors managed with testis-sparing surgery. So 9 patients in this study underwent partial orchiectomy, of which none ultimately experienced recurrence, with a follow-up of about 3 years. I will note, however, that 2 of the 9 patients did ultimately undergo conversion to a radical orchiectomy because of a positive margin on pathology. And we recently published this paper in the Journal of Pediatric Urology looking at prepubertal patients with Leydig cell tumors. And we found that on the pathology specimen, you could actually identify signs of spermatogenesis. This is tough to see, but we do have some arrows showing signs of spermatogenesis in the seminiferous tubules in patients who we would expect to be prepubertal otherwise. So we don't really know the implications of this, and it's likely due to paracrine stimulation from testosterone production. But we do question whether this might have some fertility implications in prepubertal patients and other, not only in testis tumors, but in other malignancies for fertility preservation considerations. So the next sex cord-stromal tumor we will discuss are Sertoli cell tumors. These are even more rare than Leydig cell tumors and represent less than 1% of all testis tumors. So they are primarily benign, but there is a systematic review of all patients with Sertoli cell tumors, both adult and pediatric, that did identify approximately 50 patients with metastatic disease, which was primarily in older children and younger adults. Risk factors for metastatic disease in these patients include older age, larger tumors, cord extension, lymphovascular invasion, necrosis, and a high mitotic rate. These are generally treated with inguinal orchiectomy. However, you can consider testis-sparing surgery in patients with smaller tumors, as about 90% of them are benign. Sertoli cell tumors are sporadic in about 60% of patients, but the remaining are associated with multiple neoplasia syndromes like Peutz-Jeghers and Carney complex. So I'll talk a little bit about those predisposition conditions. So Peutz-Jeghers syndrome is an autosomal dominant condition. This is a patient here that shows one of the characteristic findings of mucocutaneous pigmentation or some freckling of the lip area. These patients have multiple cancer predispositions, including sex cord-stromal tumors, like Sertoli cell tumors. They're also more commonly identified to have testicular microlithiasis, and this is the testicular ultrasound of the same patient, actually. So these patients are generally followed with surveillance. They undergo annual testicular exams and ultrasounds, especially if there's concerns for microlithiasis in this setting. Carney complex is another autosomal dominant condition, which shows skin pigment abnormalities. These patients can have urologic problems, including large cell calcifying Sertoli cell tumors and primary pigmented nodular adrenocortical disease, or PPNAD. They should also undergo surveillance in conjunction with the endocrinology. And this should include clinical evaluation for worsening gynecomastia, increasing testis mass size, and signs of growth acceleration. If they start to experience some of these things, especially growth acceleration, we should definitely consider treatment in order to not cause growth retardation later in their growing years. However, some patients, if they have small tumors and very minor clinical presentation, can be considered for aromatase inhibitors, which has shown some benefit in more recent literature. Granulosa cell tumors are another sex cord-stromal tumor that are quite rare. So juvenile granulosa cell tumors present in infancy, and they are benign with very limited malignant potential. You can see gynecomastia in some of these patients due to increased estrogen production. So these can be treated with testis-sparing surgery, especially smaller tumors, versus orchiectomy if you have a larger tumor. So the last one of the sex cord-stromal tumors is gonadоblastoma. These generally present around the age of 5 and 10 and are most commonly associated or attributed to DSD conditions, in which case there's a phenotypic female with underlying male karyotype, or they have an XY karyotype. So they are generally associated with dysgenetic gonads and are solid and hypoechoic lesions on ultrasound. A consensus statement was made in 2007, which outlines the risk of gonadоblastoma in various DSD conditions. And it also makes recommendations on management based on the best evidence. So this I took from Campbell's, which summarizes this consensus statement. And the important thing to consider is that the risk of malignant disease in prepubertal patients is very low. However, approximately 10% do undergo malignant degeneration to generally a seminoma, but this occurs only after puberty. And I will finish with that, as an in-depth discussion about this complex topic is definitely outside the scope of this talk. So I want to quickly touch on the most common non-testis primaries. These are generally hematologic malignancies like leukemia and lymphoma. And these are the most common things that metastasize to the testis. So these should be considered in patients with testis masses associated with systemic symptoms, abnormal blood panels, and lymphadenopathy. Gonadal disease or relapse in the testis can occur in up to about 20% of patients with very bulky disease. So we used to recommend testis biopsies in this patients, but given the excellent effect of systemic treatments, we no longer recommend routine biopsy. I'm going to give fair warning here. We're going to move on to post-pubertal testis tumors, but this is going to be a very high-level overview of what probably is one of the most common, or excuse me, complex topics for urologists and urology residents to master. and often is a urology oncology fellowship in and of itself. We will very briefly go over post-pubertal testis tumors, just to have a broad knowledge for when adolescent patients present to our clinics with testicular tumors. So focusing primarily on germ cell tumors in post-pubertal patients, they can be broken down into seminomas, non-seminomas, or mixed tumors. The workup of a presumed post-pubertal testis tumor involves a radical inguinal orchiectomy, serum tumor markers, including all three of them, the AFP, beta-HCG, and LDH, as well as a metastatic evaluation with chest imaging by either chest X-ray or CT, and a CT abdomen and pelvis. Some patients may actually present with neurologic symptoms, in which case they should undergo a CT head to assess for CNS metastases, for example, which can occur in things like choriocarcinoma. Germ cell tumors in the post-pubertal setting have very complex staging, which is based on the pathologic diagnosis of the orchiectomy, as well as the serum tumor markers, which you can evaluate both pre and post orchiectomy, as well as the metastatic evaluation. The management options vary significantly depending on the pathology and clinical staging, and they can include a combination of any of these things. So surveillance, chemotherapy, radiation, and surgery, which is generally in the form of a retroperitoneal lymph node dissection. Given the significant complexity of these conditions, it's important to consider referring complex patients to adult urology oncologists, subspecialists, and consider a multidisciplinary approach to these treatment, as a lot of the treatments do have lifelong impacts. So these patients are managed as per adult protocols. The most common one that I'm familiar with that we use in residency were the NCCN guidelines, which you can get online and go through very specific details about management. So no talk of testicular tumors would be complete without a discussion about retroperitoneal lymph node dissection, or RPLND. The first thing I would like to mention is that RPLNDs can be very morbid procedures, especially if there is an inadequate section or injury to surrounding structures, nerves in this area specifically. So these should be completed by fellowship-trained, high-volume surgeons with the most experience with RPLNDs to give these patients the best chance for good success and outcomes. RPLND is a very important operation for certain advanced germ cell tumors, and it's primarily done in post-pubertal patients and rarely indicated in pre-pubertal patients. As mentioned, it's a significantly morbid procedure in children. So the template borders for an RPLND include the renal hilar vessels superiorly, the ureters laterally, the common iliac and ureter intersection inferiorly, and the psoas fascia and anterior spinous ligament posteriorly. Lymphatic drainage of the testicles is extremely important when proceeding with an RPLND. Retroperitoneal lymphatic drainage goes from right to left. The primary retroperitoneal landing zones from right-sided testicular tumors are from most to least common, the intra-aortic caval lymph nodes, followed by the paracaval and para-aortic lymph nodes. In the left-sided testicular tumors, the primary landing zone is the para-aortic lymph nodes, followed by the inter-aortic caval nodes. So the second image here outlines the RPLND templates for both right and left tumors respectively, and this is based on the primary landing zones and the RPLND borders. So in this image on the left, we can see significant left para-aortic lymphadenopathy, which is correlated with the patient's CT scan, which shows the large mass in the retroperitoneum. So we can see the IMV, which is reflected laterally, and then the aorta and the bifurcation of the iliacs is also noted here. The IMA is intimately associated with the mass, and in the right image, you can see that this is the same patient. Everything was cleared out very nicely. The mass is no longer there, and we don't see any lymphatic tissue in the border of the RPLND. So all overt masses and lymphatic tissues were removed up to the level of the renal vein. So I'm going to finish up this talk shortly, but very briefly I wanted to discuss an important aspect of the care of patients with testicular malignancy that I'll call testicular cancer survivorship. So it's really important in pediatrics to consider the long-term and lasting impacts of conditions such as testicular cancer and consider what we can do to prepare patients and families. One of the biggest concerns around secondary malignancies in patients undergoing treatment for testicular cancers, these secondary malignancies can arise as a result of specific treatment modalities, including chemotherapy and radiation, as well as predisposition syndromes. One modifiable risk factor is related to our surveillance protocols, and testicular cancer is a disease of young people, and many conditions require ongoing imaging surveillance. So CT scans of the abdomen and pelvis are some of the highest radiation doses, and the cumulative risk over time in young people is very significant. So this is why it's really important to consider other methods of surveillance like following serum tumor markers, which we discussed a little bit earlier, if at all feasible and without sacrificing oncologic outcomes. Fertility preservation is also of significant importance when counseling patients on treatment of testis cancers. Germ cell tumors at their baseline have associated fertility issues, with 52% of patients being oligospermic at diagnosis and 10% azoospermic, and this is without any treatment whatsoever. About 100% of patients become azoospermic with chemotherapy treatment, although about 50 to 80% of these return to pre-treatment sperm levels within 2 to 5 years post-treatment. RPL&D can also impact ejaculatory function and impair fertility through that means. So in patients undergoing treatment for testicular malignancy, it's important to send them for upfront assessment to consider fertility preservation, which can be done either pre or post orchiectomy. So we arranged this very urgently with our colleagues at Mount Sinai, and I put up a bit of information on fertility preservation in malignancy in Ontario, including the website, which has lots more of logistical information. So lastly, undergoing orchiectomy can have some psychological impacts on body image in patients, especially as they grow into adolescence and young adulthood. It's important to counsel patients that there is an option for testicular prosthesis insertion in post-pubertal patients should they desire it. And in Ontario, this is covered by OHIP, and I believe that's up until the age of 18, but many people are unaware of this unless we bring it up, so a really important thing to do. So on that final note, I want to end off by thanking Dr. Lorenzo, who was instrumental in mentoring me for this talk, as well as took the time to review many of his patients and his surgeries to help provide some context to what we discussed today. And he's helped moderate the session as well. And thanks everyone for your attention and interest, and I'd be happy to discuss things further and do my best to answer some of the questions you may have.
It was a lovely talk, Daniel. Thank you so much.
My pleasure.
I think we have a couple of questions that Mike did answer as we were going along, but maybe we'll just go over some of them because they might be of value to the bigger group. So we have a question from Surendra, just regarding the relative risk of contralateral testicular tumor. Does this remain 12 times increased irrespective of prior chemotherapy for the ipsilateral tumor? Yeah, so I guess that's just a question about whether or not your risk remains elevated regardless of prior therapy. Anybody want to comment more on that? Mike did answer that the risk factor is irrespective of prior treatment, which is why it's quite important to counsel patients for continuous monitoring.
Yeah, I agree. And I think that one of the other things that I had mentioned a little bit about was the germ cell neoplasia in situ. So if that's found in one testicle, there's a higher risk of it being also identified on the contralateral testicle. And when you have this predisposition, you often do develop a testicular malignancy. So the risk is higher for some probably underlying reason that we're not really for sure about, but GCNIS is probably implicated here as well.
And then we had a couple of comments from Dr. Chitnis in South Africa. So the first is quite interesting. I didn't actually know this, even though I do work there, is that schistosomiasis or bilharzia is quite a common cause of testicular microlithiasis in South Africa. So that's obviously an infectious cause that would be treated with, anti-infectious protocols. He also had some comments. I think I just want to, he asked about calling it a radical inguinal orchiectomy, just kind of with the, why do we use the word radical? Many places do the procedure, the same procedure, but just call it an inguinal orchiectomy. I think it's just one of those cases where perhaps language is quite important to understand just that adding the word radical, for me, also just differentiates this from, I think, sort of just so in the minds of the people who are busy operating, that we're doing a different operation to an orchiectomy that we would do for torsion or for any other reason. And just to remind ourselves that we're taking all of those oncological precautions that we do when we're thinking that this is a tumor, rather than what we're doing an orchiectomy for benign disease.
Yeah, I think that's exactly what I was going to say, Karen, is that it's the radical, including which would include, you know, the tunica vaginalis and the entire the cord in exactly as you said, different than maybe what we would call a simple orchiectomy, which you can open the tunica vaginalis and take just the testicle itself. Maybe just a little bit of nomenclature, I guess, I'm not sure.
Also, sorry to just chime in, but I agree that nomenclature also in your mind makes you think about the steps a little bit differently. The early control of the cord, and probably the most common mistake that we see in the patients that are referred here after orchiectomy, is that the cord is not taking its entirety, and part of it is left in the inguinal canal. And that principle where if you're going to do an orchiectomy for cancer, you should follow the cord all the way to the internal ring and drop it in the retroperitoneum, as you well indicated, Dan.
We had some thank yous from Fardad. Nice to see you on our list. Thank you for joining us.
Fardad.
And then Dr. Chiknas again, does orchidopexy before 2 years of age reduce the risk of malignancy in the intra-abdominal impalpable testicle? So if we do follow those guidelines, just to go back to this, if we do follow those guidelines and get these intra-abdominal testicles down into the scrotum before the age of 2, can we reassure parents that the risk of malignancy has been decreased by our procedure, or do they still need to remain vigilant? Dan, I'll let you answer that.
Yeah, I think that there's a couple of factors here. So we definitely saw, and I mentioned that the higher the testicle, the more likely the risk for malignancy. So intra-abdominal testicles obviously being at higher risk based on those registry studies. But the benefits of, so this is if it's an orchiectomy, if it's an intra-abdominal?
No, I think we're just talking about an intra-abdominal testicle that gets orchidopexy, yeah, like we do.
Yeah, so bringing the testicle down earlier and definitely pre-pubertal reduces the risk of malignancy, but does not eliminate that higher risk. So I'm not sure if there's a varying difference in the literature between bringing it down based on being 2 or less or older than 2. The main one that I found was the pre and post pubertal. I'm not sure if anyone else has any insights on that.
Yeah, I think it's actually quite interesting because we do always talk about, you know, we've got good evidence in the post-pubertal population, but yeah, there's no, like, I don't think there's a clear sliding scale anywhere that says that if you bring it down by 1 versus 3 versus 5 versus 7, that you're making a huge difference to the risk. And this is often quite challenging, I don't know, especially now when OR times have become quite long. OR waiting times have become quite long just because of various things that make it difficult to get patients into the OR. And when you consider an impalpable testicle, which is usually a stage procedure, so it often takes you a good 6 months to get the testicle into the scrotum, even if you do the first stage immediately. And that this is often something that parents ask us about. And they start to get very anxious around 18 months to 24 months of age. And they really start to worry that the testicle is not down yet. Yeah, so yeah, as Dr. Chitna says, parents are questioning us about this as we're not able to do routine operations due to the pandemic. And I think this is something that has been experienced everywhere. And also waiting lists can sometimes be long, even in non-pandemic times, just because of, you know, demand and resource availability.
Yeah, we're definitely having the same problem.
Yeah. I think we really do try to prioritize these intra-abdominal testicles and get the process done as soon as possible, but obviously, you know, it competes with other emergent issues. Are there any other comments, either from Dr. Lorenzo or Dan, or any other questions from our audience members?
No, I think we're good, Karen. I think that this talk was very well delivered, Dan, and I appreciate the participation from our friends from Canada and all over the world. And hope to see everybody again at the next session that we'll be hosting.
Thank you, guys.
Thank you very much.